So, good afternoon, everyone. It's 6 p.m. Bahrain time, 5 p.m. Cairo time, and welcome everyone for our series of Wednesday didactics. We have passed rapidly through ovarian cancer and then endometrial cancer last week, and today we are going. Last week we started with the cervical cancer, which is the vaccination part about HPV vaccination, and going from the primary prevention with HPV vaccination to the secondary prevention, which is the screening and the pre-invasive cervical lesion, the management, what do we mean by screening, what to do. And to have someone to speak about this, we will not have someone better than Dr. Samy Ismail, Professor of OB/GYN and Gynaecology in Egypt and in Germany. Really, he is one of the real experts in that field. He is one of the best who uses the hysteroscopy and colposcopy and can interpret it and has invented his own wheel that I use so much in practice. Dr. Sam, it's our honor to have you with us tonight for the presentation and to go without due delay. I know today is a very long topic, so the floor is yours. Thanks for accepting our invitation.
السلام عليكم. شكرا جزيلا دكتور باسل for your invitations, and I hope that the audience can get benefit from my presentations. My name is Samy Ismail. I'm going to talk about the pre-stages of cancer cervix. Usually we are saying it is pre-stages of cancer cervix or cervical intraepithelial neoplasia, CIN. This is the common term, or cervical dysplasia, carcinoma in situ. All these terms can be used. I don't have any conflict. السهم ده كده يا باسل. I don't have any conflict of interest. So I will go for incidence, age distribution, etiology, pathology, diagnosis, and therapy. And I think I will jump in many slides for me because Dr. Basil last week, he gave a good presentation about many of items which I'm going to cervical intraepithelial neoplasia according to the age. Always that these phases differs from each other by 10 years. The dysplasia, the incidence of age here, 25 to 34 years. Carcinoma in situ, which is the maximum of the dysplasia from 35 to 44 years. Carcinoma itself from 45 to 55. Regarding the cervical intraepithelial neoplasia incidence itself in Egypt, it is 3.5 per 100,000. Germany, it was 20 per 100,000. South African. And I hope that the incidence, this has not been changed. If it has been changed, I will be happy if anyone to correct it to me. So regarding the etiology, I think this is Dr. Basil last week, he gave us the etiology before starting the HPV. Etiology lasting in three main factors: the epidemiological factor, initiation factors, and the promotions factors. Epidemiological factors, as Dr. Basil said, early stage of cohabitation or early age of first intercourse, many partners, many deliveries, bad genital hygiene, low socioeconomical status, and they were saying before it also this is the presence of non-circumcised male, but this issues is not solved because actually in our countries or our cultures, we are circumcised, we don't have the incidence or statistical to say that. After the epidemiological factors, the initiation factor, which HPV 16 and 18s, and we added also, of course, the other high-risk groups. Promotions factors, that is smoking, is very important. It is that they promote when the presence of the epidemiological factors and the initiation factors. Anatomy of the cervix, because we are talking about or working with the cervix. I will leave the gross anatomy. I will go mainly for histology. In the histology of the cervix, two types of epithelium, squamous epithelium and columnar epithelium. And in between of both, the transformation zone or squamocolumnar junctions. And then when I was in Germany or started to study the colposcopy test, I always asking, what is this squamocolumnar junction? It is different. I don't see it. We present here, this is how we are seeing it as a squamocolumnar junction. The ectocervix is multiple layers of squamous epithelium. It is basal, parabasal, intermediate, and superficial. Well, endocervix is only one layer of columnar epithelium, and we will see why when ectopy happens, why it looks red, because ectopy means that is the endocervix is coming outside the squamous epithelium or replacing the squamous epithelium. So the underneath vascularity, it appears on it. Then the squamocolumnar junction. Here it is diagrammatic or schematic graphic كده showing that is the squamocolumnar junctions with the 4 layers and the squamous columnar epithelium of the endocervix. Here this is the area of the junctions between, and this is the junction is moving forward and backward. And we see here multiple layers of the ectocervical or squamous epithelium. Here is the histological presentations of with the graphic. Here is the squamous epithelium, and here's the columnar epithelium. And we see that is here, it is the junction between both of them. It will come clear when you are working much with the colposcopy. Here that is again squamous epithelium and columnar epithelium, one layer, and the junction between them. It is the squamocolumnar junction. What is about the zone? Squamocolumnar junction, the transformation zone, it is the area which initiated and replaced when the squamocolumnar junction moves from side to side. So this area of they are saying in Germany Umwandlung، يعني اللي بتتمشى دي رايحة جاية دي بتتحول للترانسفورمation zone. Graphic also, it is the columnar epithelium of the endocervix. It is always we see it always after the application of acetic acid. It is a grab-like structure. Here is squamous epithelium, and this is the transformation zone. Okay, we can consider this is the junction between, but it's the zone which is moving. It has a different places at the just after the delivery, the original squamocolumnar junction, it is up a little bit. In age of reproductions, it comes down, and we see always that is the terms or the picture of ectopy or erosion, that is, we can say it in the old terms, erosions. Then it comes again at age of 40 to be moved again to the endocervix, and in the menopause, it moves very high up. That is the idea why we have to know that is the position of the squamocolumnar junction, because if we are going for treatment of cervical interepithelial aplasia, you have to remove and treat the squamocolumnar junction, out to reach to it. And if you are going for conization, you have to reach the apex to reach to the squamocolumnar junction. Okay, cervical interepithelial neoplasia, sometimes it is subjective, the diagnosis by early symptoms. The common is postcoital bleeding. But the screening methods through the cytology, through the colposcopy, and histopathology. How to screen should be simple, cheap, accepted with low false negative. How do the pap smear? Actually, we have to give the instruction 24-hour no intercourse, 48 hours no vaginal touches, and 1 week no vaginal cream. Actually, we are not stuck much with this thing because we are trying to catch that is the patient or the lady for the screening. Yani. But ideally, we have to follow this. How to take the cervical interpretation of the smears. Whom to screen? Anyone who had sex in her life or started her sexual activity. And when to screen the pap smears, this is again at the age of 25 in the state, they were saying it's 25, and usually at 21 years. But in Germany, they are saying that is first pap smear should be taken after the first intercourse. How frequent, according to the national programs or guidelines, that is maybe is every year. Germany was taking every year. In Europe, other countries, 3 years. Has been replaced also now to تباعد ما بين السكرينينج if you have HPV testing and genotypes. Again, whatever the age or the guidelines, you can consider early screening في high risk patient اللي هم multiple sexual partners. Again, onset of sexual intercourse at an early age. HPV infections is open for the people, especially with the high risk HPV. History of sexually transmitted disease and HIV infection, immunosuppressive with smokers. And how did they acknowledge that is the importance of the smoking in the affections or the promotions of the cervical intervention? Because they found some tobacco excretion in the cervical mucus. That's why they gave the attention to the smoke. Again, that is the pap smear that is through Papa Nicolau in USA, who is a Greek. Here it is a easy, very easy and very cheap and excellent site to get the exfoliative cells from the cervix, ectocervix, or we see here the exfoliations. And again, here all normal, and when it is replaced by dysplastic changes. How to differentiate between normal and abnormal cervical cells? In general, as I said last week, that's usually each department in gynecology has a cytology lab. And the gynecologists there, they have to learn how to interpret the cervical cytology. And it is very easy. What is the difference between the normal cells and what is the difference between the abnormal cells? The atypical squamous epithelium, it has enlarging, misforming of cell nucleus, enlarging and multiple nucleotides or nucleus hyperchromatism, clearly disproportion between the nucleus and the plasma relations. Again, this is the normal, superficial, intermediate, parabasal, and the basal of the squamous epithelium of the ectocervix. We see that the difference in colors according to the acidity or pH of the cells itself. Here it is the normal pap smears of the superficial ectocervix or squamous epithelium. We see that it is very fantastic, good pictures. Is again here many cells which are all normal. Please remark this is the proportion between the nucleus, how the nucleus is appearing, how the cytoplasm is appearing. So you will see the abnormality, you will get it. Again, it is the columnar epithelium here, and this is the stroma underneath. Here, the columnar epithelium sheath. This is a schematic or diagrammatic presentation of the abnormal cell. We see that the cytoplasm is fragmented or beaded. We see the nucleus is enlarging, hyperchromatosed. Okay, this is the abnormal. Here is normal or a little bit abnormal, mild abnormal cell. Another forms of severe dysplasia, our calling this is cervical CIN3, another form of abnormal malignant or severe CIN3. Again, it is a mix between the normal cells. Here it is the normal, and here it is abnormal. Here it is abnormal. Here it is abnormal. Look for the nucleus and the proportion between the nucleus and the size of the nucleus and the cytoplasm. It is easy to be diagnosed. Another one, look how the one cell has been enlarged and with multiple nuclei or nucleotides. This is also a severe or reaching to carcinoma in situ. You can imagine that is all these one cells and how much or how many nucleus inside it. One cell here is here there, and how many nucleotide in it. Abnormal also cells, here cells, another here with 3 nucleotides. It is very important to diagnose between pre-invasive or pre-stages and invasion of the cancer. There is a basal membrane between the squamous epithelium, multiple layers, and the stroma. This usually the key words here, this is the basal membrane. If the basal membrane not break down, so it is always going with the pre-invasive or CIN3 or even carcinoma in situ, whatever. So how we are differentiating or are saying it is CIN1, CIN3, CIN4? It is depends on how the incidence of replacing of the squamous epithelium, these multiple layers. We are dividing it to 4 parts, 1/4, second fourth, third fourth, and complete replacement. Here it is looks like CIN1, here is CIN2, and here CIN3. If it is replaced completely, we are saying it is carcinoma in situ or CIN3 severe dysplasia. This again, whatever, as long as the basal membrane is intact, no invasion. But we have to take that to take in consideration when we are treating this. We have to treat it deep because there is some glands in the stroma, okay, above the basal membranes. We have to reach in treating it. There is many classifications for the pap smear. That is the recent one which we are applying it is the Bethesda classification. Before the 90s, there was a common classification, Papa Nicolau classification, PAP 1, PAP 2, PAP 3, PAP 4, PAP 4, but it is not now used. And the CIN classification, CIN 1, 2, 3, 4, or carcinoma in situ. But we are always now considering that is the Bethesda classification اللي هي ASCAS, low squamous intervascular lesion, high grade squamous intervascular lesion, or squamous epithelium. You will receive the report according to the findings. They are telling you that is the specimen unsatisfactory or specimen is negative for malignant cells, or it is abnormal, or في atypical squamous epithelial, ASCAS undetermined significant, ASCAS with the potentiality of the high risk, low grade squamous intervascular, high grade, all this you will receive these terms or the diagnosis. It is very important also that is the glandular lesion or atypical glandular cell, because when you have in the pap smear the atypical glandular cells, you have to look for the endocervix, because the atypical glandular is coming from the columnar epithelium of the endocervix. ايه الكلينيكال امبورتنس اوف ذا سي اي ان؟ ليه احنا مهتمين بكده؟ وانا وقت بعيد كان في التسعينات لما كنت في المانيا، كنت بشوف في الليسته مثلا عندنا 5 6 كل يوم كونايزيشن، وبعدين بسال التشيف ارتس بتاع ده، فبقول له انا مش شايف كتير كانسر سيرفكس، فقال لي it is a shame to find the cancer cervix and you have a very cheap and very excellent method to diagnose. يعني ده العيب فينا احنا، ان احنا نستنى لغايه ما نوصل للكانسر سيرفكس. فكان يعني عجيب ان انا كل يوم اشوف الكولبوسكوبي، كل يوم اشوف الليست الكونايزيشنز بتتعمل او كده. Regarding the severity of the CIN, usually it is لا اما progressive او regressive. والحمد لله ان most of them are regressing. يعني الكوامس CIN و CIN2 usually behaving in a regression way. CIN3 is progressing to cancer cervix. And we shouldn't forget that is always there is enough times or durations between CIN1, CIN2, CIN3. يعني you have a time to diagnose and to treat. يعني and the treatment is 90% can be effective. يعني you are saving lives. Colposcopy, it came for the first time from Henselmans in Hamburg, in Germany. It is a picture of it. Of course, it is many new versions of it. The procedures and the technique, I think that's all of you knows how the lysotomy position, colposcopy, all this expose the cervix. The common questions in the exam always for pre-invasive courses or whatever, which fluids or solution we are usually using it. This is mainly there are four solutions. This is the saline, that is the acetic acid, the iodine, Schiller iodine, and that is the hemostatic solution, اللي هو Monsell solution, but it is not mandatory because you can use the silver nitrate sticks. Iodine has been regressed. يعني we are not using much iodine. We are using saline to remove the mucus, and then the acetic acid. And the acetic acid is very essential because if you don't have colposcopy, don't stop to examine the patient or the cervix with the acetic acid. There is acetic acid visualization test, and it is approved by WHO also. indication امتى نبعت العيانه for colposcopic examination. unhealthy looking cervix، انت شايف السيرفكس ده you are not happy with it. ودايما ما هتشتغل كتير بالكولبوسكوبي في السيتولوجي والاكزامينيشن بتاع السيرفكس، هتعرف انت بتقول انا مبسوط من السيرفكس ده او انا مش مبسوط، انا مش مريحني السيرفكس ده. بوست كويتال اند contact bleeding, post menopausal bleeding, repeated instrumental bleeding, valval wart وفي الاميونوسبريسيف patient. If it comes after the pap smear, if the pap smear coming with the invasion of the carcinoma, severe dyskaryosis discrepancies, mild moderate dyskaryosis, nuclear changes, persistent unsatisfactory smear, you are seeing something and always they are sending to you, it is unsatisfactory, it is not enough. At these times, you have to be in doubt. Excessive keratinized cells. Management of the CIN according to the pap smears. If it is low-grade squamous, of course it is normal, خلاص routine. She will be in the guidelines. Inflammatory, you have to treat an infection, you have to treat inflammation, and after the therapy, you have to control again with the pap smear. Low-grade squamous enterothelium, you can control after 3 months, or you can go for multiple biopsies, excisions, alconization. Carcinoma, of course, you have to go for the cancer cervix. This again, low squamous intraepithelial lesions, 60% reversibility بتاعتها. في اللو grade persistent, go for histological examination. When I'm saying histological examination, I mean that you are going for directed biopsy. It is again the same. Acetic acid, as it's 3%, we Schiller iodine. It is staining the cells of the cervix with a deep brown نتيجة الreaction between الأيودين and glycogen content of the cells. In international colposcopic finding, you will see that is normal finding, abnormal atypicals, or different finding, and you will see it. Now we will let us to see the different pictures of the colposcopy. Here it is a very nice look to the epithelium here, or the ectocervix is clear. Here is the squamocolumnar junction. Here is the squamocolumnar junctions here, if you see it. This one. It is a cervix of a postmenopausal woman. It is, we will find it is the rose color is disappearing because it becomes atrophic. The external cervical os becomes narrowing, and we see this is the squamocolumnar junction a little bit moving upward. A picture of the ectropion. It is a healthy cervix here, because that is the columnar epithelium replaced all the ectocervix, so the underneath vasculatures, it appears with the red coloration, which we were calling it erosions. It is not erosion, it's actually. If you wanted to see the squamocolumnar junction, it is here. Okay? It is here between columnar epithelium and squamous epithelium. Another pictures of the cervix where excessive mucus secretions after the removing with the saline and with the acetic acid. We will see. This is the columnar epithelium, looks like a grape-like structures. We are seeing the opening of the glands here after removing of the mucus. And if you would like to see the squamocolumnar junction, it is here, 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 again. It is normal finding. Is again also ectropion with the grape-like structures of the columnar epithelium after the application of acetic acid. The squamocolumnar junction is here. Okay. This is the pictures, and if we are going for extra magnifications here, that is the squamocolumnar junction. What is the columnar epithelium? So, if the time Basil passing, tell me, yeah.
No, we have like 45 minutes, for still we have at least 20 minutes.
طيب, okay. Here again, it is the columnar epithelium with squamocolumnar junction. I'll try to go. Ectropion also, this is again columnar epithelium, squamocolumnar junction going down. It is mandatory to see the squamocolumnar junctions. Vascularizations, the normal vascularization of the cervix, it is very important, because when you are going to the cervix, you have to start before application in anything. You have to start with the green filter to see the vasculature better. Abnormal vasculature, the coma shape, mosaic appearance, fragmentation of the blood vessels, bleeding, abnormal vessels. Look for the abnormal vessels here. This again, it is vessels. It is normal here. It is not abnormal. But here, look to the mosaic appearance of the vasculature. This picture was of CIN3. Okay. Punctation or coarse or fine punctation, it is suspicious. You have to biopsy this area. It is normal. It is again, it is an area of negative aceto-white area. It is here. And if you see also, there is a fainting area of aceto-white area. The difference between the term of leukoplakia and aceto-white area is just leukoplakia, it's a whitish area before application of acetic acid, but it increasing with the application of aceto-white area. It is the area which appears after the application of acetic acid. Again, here, a small area of leukoplakia and aceto-white area, and it becomes again is an iodine negative. Again, area of negative. It is the pictures of gross leukoplakia. It is always here. With this picture, it comes carcinoma in situ or invasive cancer. Again, another area of leukoplakia or of aceto-white area. It is the picture before application of acetic acid, and after the application of acetic acid, we see the area. It is CIN3 or carcinoma in situ. Again, cancer cervix here, these pictures. Cancer cervix again. Okay. So you have to, after finding all these things, if you find this leukoplakia, aceto-white areas, negative iodine, you have to go for direct target biopsy or directed biopsy. It is the pictures how to take the biopsy. Indications of conization, high-grade squamous intraepithelial lesions, evidence of dysplasia high-grade. Always there is a discrepancy between your finding in colposcopic or the pap smear's result. If you are in doubt, don't hesitate either to take a biopsy or even you go for conization. Again, the shape of the conization depends on where is the squamocolumnar junction. You have to include it. In the age of the reproductive young age, the base of the conization should be broad and the apex is short. And the postmenopausal, the apex is high and the base is narrow. It is again graphic presentations. You have to get the lesions out. A step of conization, I think that is all of you knows it. It is demarcations, then apply acetic acid or iodine, go for colposcopy if you want, وبعدين inject أو ligate descending branch of the cervical descending branch of the uterine, وبعدين go cold knife, laser or diathermy. Debate between diathermy ولا cold knife. Some people, usually I like the cold knife. Some people say that don't use the cautery because the margin we cannot touch, you cannot judge it, but it is valid. Complication, bleeding. No one to go for conization without taking permissions or consent for possibility of hysterectomy. I will leave here for all you, or I'll send you through Dr. Basil, the flow chart for management of abnormal pap smears, whatever here. It is negative for malignancy, but it is abnormal. Either في endocervical cells, inflammatory, endometrial cells. We can share with you all these pictures as a flow chart, and we abnormal pap smear with pregnancy, no contraindication for colposcopic examination during pregnancy, no contraindication for cervical biopsy, even conization, alas. But the definite treatment should be deferred at least until the end of the puerperium. No special recommendation for management during labor with the ladies who have CIN3 or pre-invasive carcinoma. We developed it as a wheel like which we are using in the pregnancy calculation of pregnancy. If you have a finding according abnormal pap smear, for example, ask us high grade, what you have to do, you have to go for one colposcopy. It is easy. We hope that we can print a lot of amount of this wheel and we can distribute it. But it is involved in this book. It is also free for anyone who wants, but through Dr. Basil. It's a book to be taken. Either you're paying 10,000 جنيه, this is the cost, or one دعوة يعني. حد يدعي لنا. Okay. This is again Ismail wheel for management of the abnormal pap smear. Some good news for the young fellows. This is IGCS launching 2020-26 the global observership program. I think the young fellows can go and check in the website for these programs. They can apply. This is a program for the observership only. It is for 2 months. all over the world. Yeah, and we are starting with 10 sites for observations, three in Egypt, inshallah, one in South Africa, the rest in UK, USA, and Germany. This is the first 10 sites which we choose, but it is a very good, yeah, just observation. But يعني, I think it is when you are in a good center, it's just you are going for observations, and so you will get a lot of benefit. It's a very good programs. It is this one. Expectations, yeah, always 1 or 2 months for the young gynecologist who is not finishing the program. Okay, I will just send Sharia if you have any question regarding this program to send it to these coordinators or sending to me, whatever. يعني, but don't lose the chance for this. I think that is IGCS are playing a very good roles and major roles in fighting against the cancer. Thank you very much. I'm sorry that it was a long presentation.
No, thank you indeed, Dr. Sami. I think very interesting presentation, and I think this is the type of presentation that gynecologists really like, يعني, because they learn a lot. So, can you stop sharing the presentation?
Uh, how?
Yeah, now it stopped here.
Stop here.
Yeah, just stop sharing. And now we are open for the all discussions. Any questions from Dr. Ahmed Soudan is asking you, is thanking you from Egypt.
Thank you also from Egypt also.
Oh, anyone have question or comment to Dr. Sami? It looks like it was an easy, straightforward. So for the wheel really, it was very interesting. I had many copies in distributed in Egypt of the book and the wheel as well. So if anyone just wants the wheel, he can contact Dr. Samir, can contact me. Dr. Abdallah is asking, thanks, Prof. Sami, but can we use the Swedish classification for the colposcopy?
No, yeah, because it is according to the finding of the colposcopy. What you find, how to management. Exactly like, yani, we have many wheels. Yani, we have wheels for uterine cancer. We have wheels for cervical cancer. It depends on the diagnosis. Yani, you have to have stage 1, how to deal with it. Stage 1A, how to deal with it. Yani, just when you are sitting to know what is you have, the final diagnosis of high-grade squamous enterothelial lesion, the level wheels, and you get what you have to steps to do.
Okay. We have a question from Dr. Elma. She's asking, what is the optimal follow-up strategy for CIN1 in women over 30 with persistent high-risk HPV infection?
No, that is again, if she completed her family, it is always the, and you have to be on the side of either conizations or even this is the hysterectomy. But if she doesn't complete her family or she's refusing the idea of hysterectomy or conization, this is a strict follow-up with them. Be free when you are doing much pap smears, when you are doing much colposcopy. It doesn't cost, even يعني, if we have a good circumstances, it is beside you or in your office, the colposcopy. You can prepare it in 2-3 minutes.
So, Dr. Sami, what do we mean by persistent HP infection? So, يعني, I know for my knowledge, I'm not the best in
No,
colposcopy.
persistent lesion. يعني again,
يعني how long it is to say persistent? If I have L cell or يعني CIN1, which is L cell, I will do a repeat pap smear after 1 year. And, okay.
مم.
So, what do you mean by persistent? Is persistent for 1 year, for 2
لا يعني الابن هو السي اي ان ده موجود وانت سي اي ان 1 وان انت بتشوف الجينوتايبس.
مم.
يعني if it is high risk يعني at least keep
سين
her
او
for
18 او
6 months
كده.
or 1 year.
مم.
Don't lose her. If it
مم.
is the genotype is negative,
مم.
you feel free that is you are give her 2 years, 3 years. But again, because the facilities is available here, we are
مم.
catching them.
مم. Great. So Dr. Wadia Gherbal, I think she is in Malaysia now. She's, thank you, Prof. Sami. What you prefer to do for 52 years old patient post-leap for CIN2? So she is 52 years old, post-sleep for CIN2 with persistent high risk 52, 53 HP till now. Colposcopy last year LSL. Can you see the question, Dr. Sami? If you open the Q&A, you can see the question because there is
in the chat.
in the Q&A box, not in the chat, in the Q&A box.
Yeah, but I got the question. That is if it CIN2 and
Post-sleep,
after
Colposcopy report.
conization, that
Yes.
you have يعني, to stop to follow up. You have the
Mm,
option for follow up. You have the options of reconization if you
mm,
feel that the margin is not free. Okay, if the patient is not happy or worried, much worried, okay, it is valid also to go for hysterectomy. يعني
yes.
أو
Yes. Years old.
compliance of the patient is bad. Okay, finish the story. And also don't forget to give HPV vaccines after the treatment in CINs 2 or 3, whatever.
Yeah. Thank you, Dr. Sami. So, do we have any other questions or comments? So, really, thank you so much, Dr. Sami, for this
Yeah,
very
welcome.
interesting presentation. It was recorded and it will be published on our YouTube channel, and I'll send it for the group on WhatsApp. And meet you next week, I hope, inshallah, to speak about the management of early cervical cancer to go for the radical hysterectomy and type of hysterectomy. I'm going to speak about that. Thank you, Dr. Sami, so much, and
Okay.
we are
Yeah,
waiting.
welcome.
We are
Thank you very
waiting for
much.
more and more interesting presentations from your side. Thank you, Dr. Sami.
Thank
And
you
thank
very
you
much.
for everything and for all support. Thank you.
No, thank you.
Bye bye.
Assalamu alaikum.